outcome for leveraging assets and research. Before we begin, I would like to thank our sponsors, mainly Aon, for providing the location for today's event. Aon is a global leader in professional services, providing range of solutions for risk management, health solutions, which are related to insurance and reinsurance, human capital, as well as data analytics. I also would like to thank NumFOCUS, which is a nonprofit organization that supports and promotes development and adoption of open source scientific softwares. So thank you, and thank you for patient with us for being so late. Now we are ready to listen to the talk. Thank you.
Thank you. Okay. Hi, everyone. Thank you, Sojeng, and thank you, Mehdi, for setting me up. So let me find the talk. Oh, it's right there. It's not what I'm looking at, but I can look at it there. So I am Rosalind Chua. I am a faculty in the School of Computing at DePaul University. And like you said, I'm here to talk about Scholar. That's it's a nice acronym for a very long title. And we will discuss what it means. So I will.
Is it working?
And no. Okay. Oh, I can do, no? Maybe I need to be on the PowerPoint.
Okay, one sec. Okay, try now.
Okay. Oh, it's not doing like you were doing.
Okay, one sec. Okay.
Okay.
Go with
It's these ones.
Yeah.
Okay. Thank you. Thanks for your patience. So my talk is broken down into like a background of who I am, who Sinai is. Kelly is able to join us, so we can have questions about Sinai too. But just the background about how we got together and the project, and then we get into the project. I realized that maybe this group likes code. I don't have code, but I have good ideas, hopefully, because our group is into applied research. So we don't do, the way we innovate is in the way that we apply the research most of the times. Okay, so DePaul University, what I want to say about that is the mission, actually I should have said that too, my eyes are not that great. But through education and research, the university addresses the great question of our day, promoting peaceful, just, and equitable solutions to social and environmental challenges. So DePaul is a big part of Chicago. They like to say that they're, they produce the workforce of Chicago. We're pretty good sized university for the city. And the School of Computing is one of the biggest schools there. My collaborators at this DePaul are Daniela Raiku, Jacob First, Jamshid Surati, and then we also have John Maziro, who is in the College of Health, because this problem is about data science and health. The other one, yes. And then this is great because this is PyData Chicago. DePaul is in Chicago, and Sinai is in Chicago. So Sinai Chicago is one of our hospitals here. It's one of the biggest hospitals. It's a big safety net hospital. And in addition to their hospital care, their ambulatory care, they have community services for the city of Chicago. And then they have a research arm that is called Sinai Urban Health Institute. So if I say SUHI, that is what I mean. So they have an arm that does research, and there's a big piece of community health research in that in Sinai Chicago. And they also have a vision for all communities to strive in health. I'm going to get used to that. And then so what happens is in 2020, the two institutions signed an agreement and decided to have more, to facilitate more project between the two institutions because we have a shared vision. DePaul's vision and Suhi's vision of justice and equity challenge, health equity challenge in Chicago fit together. And I was a research fellow, a Suhi equity research fellow in 2022. And that is how I met Kelly McCabe, who is my co-partner at Sinai. So I wanted to say a little note already to set up the talk. Community health and data science, is it unlikely or a timely match? And I want to bring in the idea of responsible machine learning, responsible AI. That is a term that we're hearing more. And that is AI that is ethical, transparent, accountable, safe, and aligned with human values. Now, there's many core principles in responsible AI, like fairness, avoiding bias, accountability, developers are responsible for outcome, etc. And then I highlighted the human-centered values. AI should augment human capabilities and respect human rights, dignity, and autonomy. This is the piece that I think comes true to our project, is an AI that is augmenting human capabilities that are doing something for society. So when we dig a little deeper into that, there is a term that is being coined as human-centered AI or human-centered ML, and it aims to tackle challenges in AI, including the light of interpretability. That's important if it's going to be used in the real world, bias and fairness in ML, societal impact, including in healthcare and health equity. So HTML specifically studies social values like fairness, equality, and justice. It's an emerging field, and it's an interesting field that we're interested in, but right now there are no like unifying guidelines on how to do that, right? We want to be part of defining this process. So that's the background, and now for the project itself, and it's going to go through the evolution of what I was doing as a fellow and what Scholar is now doing. So when I was a fellow, the outcome we decided to focus on was very specific. We were trying to work together on a project for a year. So you match a scientist from universities in Chicago, but now I think other universities nationwide, with a scientist in Sinai, and they work together for a year on a project. So at the time, the project that we identified was 30-day emergency department readmissions. This is a health outcome that's important for patients, for obvious reason, because we all don't want to go to the ER all the time and go again for unavoidable reasons. But it turns out it's also a big metric for hospitals to be evaluated by funding sources like the Center for Medicare and Medicaid. You get a score for your ED readmissions, and hospitals want that score to be high or the avoidable readmission rate to be low so that they can get more funding. So that's the outcome, the health outcome that we're working on. And SUHI has its own solution to that. So they have a community health worker program that is a proven strategy to improving health outcome, including this one. Community health workers come from the same communities as the patients. So they are a link between the patient and the hospital. So a link that is more, that the patient can trust more easily. And they collect information that we call, that is called social determinants of health data. I will tell you more about what that is. And a side note that I found out through this work is that while this is a very hot topic now, more people are studying social determinants of health. And actually, as of January 1st, 2024, it became required to collect some of this information in all the hospitals. But SUHI has been doing it for more than 20 years. So it's in Chicago, to have between the university and this institution. And so a little bit more about that program and how it relates to the outcome that we picked. The social workers in the hospital refer what they call high-risk patients to community health workers. The high-risk patients are determined through a screener of some point-based assessment of how well the patient is faring. And if a patient is marked high risk, then they're referred to the community health workers, and the community health worker is the link between the patient and the hospital. Now, what they do is they will follow up with the patient after discharge and ask them if they need any services and try to provide those services. What kind of data is being collected? So you have the referral information from the social worker to the community health. Then you have some log information, some of the interaction between the community health worker and the patient. And then you have answers to that social determinant of health survey. So that's what they collect. And based on that information, they make they refer the patient to the right resources. So my question at the beginning was, can we use AI to study the impact of the CHW program and the SDOH data on readmissions? So make prediction of high-risk patients and who might be coming back to the ED. And in the process, determine what are important features or characteristics of these high-risk patients. That was our initial goal. And to make it more translational or directly applicable, we wanted to know how can we translate those kind of findings from the model into direct recommendations to the community health worker. So we would need data scientists, public health experts, and community health workers. They would actually turn to be, the center of our design. And there's a note there, my eyes won't read, but about community-centered AI, then that is putting the CHW at the center of this whole model building. So community-centered AI opportunity, what is the mechanism by which SUHI, CHW program decreased ED readmission? So that was a clear question. How can a machine learning model be refined through incorporating the knowledge of the CHW in the model? And how can the AI model lead to improved care for high-risk patients by strengthening the connections between the health system and the community? So that's where we want to do AI, but keep the human touch. It's like we're not replacing the CHW, we're trying to enhance the work of the CHW. And you can interrupt me at any time. It doesn't have to be at the end. Yes.
Give us an example. Comment.
Sure.
Yes, right there. I'm so glad that she.
Yeah, I mean, well, so unfortunately, a lot of the readmissions are due to social factors, not necessarily medical factors. So like medical reasons for readmission, like you would want somebody to come back, right? If they're, I don't know, bleeding internally or they're having whatever symptoms. But a majority of the time, especially with the patients that come to Tucson and Chicago, because we're a safety net hospital system, a majority of the time people are coming back because, let's say, they don't have access to transportation to take them to, their follow-up appointment a week after discharge that would have caught something, right? Instead, they can't attend that follow-up appointment, so they come back 2 weeks after discharge because whatever complication has now grown so serious that they come to the ER at, midnight, something like that. Transportation, access to prescription drugs is another really common one. Food insecurity is another. I mean, the list goes on and on. It's like housing, food, transportation, a lot of social determinants.
And then what is the age group of patients that come back for the readmission case?
That's a good question. Yes. The average was 60. We have patients that have a wider distribution, but the average was 60 years old. And interestingly, that was also who was mostly getting readmitted. So not very older, not much older, or not younger.
Questions for the
Oh, yes.
question.
Yes, very good. So the question was an example of readmissions. And unfortunately, which is why this work also is relevant, is at Sinai, at least Chicago, some of the reasons to come back to the emergency room are social determinants of health reasons, like transportation, lack of access to prescription drugs, and things like that. Good question. And yes, anytime, if I see questions here, I will also take them. So because this is PyData, so I also want to give you some details about what this data was. I want to say that this data was a little easier for us to get through the agreement between DePaul and Sinai than electronic health records. We spent years trying to get them. We now have them, but this data is all coming from SUHI, right? So we had data about 2,600 patients collected between 2020 and 2024, and we get new batches every so often. We have demographics and referral information, so that's basic information about the patient and why they were referred. We have log of interaction between, so how long did they stay on the phone? How long did the CHW spend looking for resources? How long were they how many times were they contacted? This kind of log. We have the survey answer, and we have something that we didn't leverage until later, but we also have CHW notes, which we can leverage for analysis as well. For the model, when we looked in the literature, most of models were logistic regression. They were starting to have more like neural networks and other type of model, but we know that those need a lot of data, right? So we try to be on the middle ground. So go up from logistic regression in terms of complexity, but not quite neural networks. So we use random forest, AdaBoost, and XGBoost as models. Yeah.
A lot of your raw data looks textual. Is that right?
There's tabular data. Most of the data was tabular, and then we added notes. So we have mostly tabular data, so structured. And actually, a lot of it is categorical. So we even the few continuous variable that we had, we discretized. So that was our data, and that's the models we chose. We wanted tree-based for explainability because it's relevant to our mission. Right? Some of the challenges that we can already anticipate and mention is that we had some data sparsity. So this is data collected from human by human. People are in a hospital setting. They don't necessarily want to give you all of the answers to so many questions. The CHW who are used to this work, they know not to ask maybe all of the question, right? So they maybe they know what they are looking at, and they may not collect all of this information. They attempt to contact the patient 10 times. You don't always have a good outcome, right? So you have up to 10 times. And then in order to keep the human touch, they actually take their notes by hand and then later record them. That also is a cause why you may not have like the fullest, most complete data. So this is some challenge. The heterogeneity, so that's your question. We had mostly tabular data, so survey answer was the majority, but we have the demographics data, which is also categorical. And we had the log information, some of them were continuous, but we just made sure that everything is discretized, have one type of data. However, we recently did integrate notes, and that's what I'm going to talk about some more. But most of the data is like this. It's just categorical answers. Something.
Wasn't too much data cleaning yet.
No, yes, no, there was. Yes.
What I'm kind of getting at.
Yes, there was plenty. And I think I touch on this here. So I wanted to repeat that this is SUHI data, so it's in-house. It was easy to get. Demographic information, logs, and SDOH, I said that. An interesting note on this slide is that how you want to probably know how many readmissions we had. We had about 32% of people readmitted, but we also had this kind of demarcation because not everybody has to agree to this program. So you have some people who decline to talk to CHW. We call them not engaged, and we called the people who agreed to talk to the CHW and provide some information engaged. This gives just something to compare patient with and outcome with some caveats. So data pre-processing and data cleaning. We actually spent, I would say, easily 2 quarters just trying to understand what the data was, how to improve it and make it ready for machine learning. Some of it was just missing, right? So some variables have so much missing that we were not able to use them. In some cases, we had to replace unsure with a yes. So making an assumption that if a patient is unsure about housing and security, we can safely say yes to try to give the machine more to learn from. We do all this in discussion with Sinai, right? So we very carefully trying to impute some in the earlier works, and this looks like aggressive imputation. It was not so aggressive. We were trying to do it carefully. Sometimes there was so many categories, like for insurance, but patients usually have just a few of these options. So merging them into just public and private, again, providing the model for more to learn from. Summarizing the contact attempts. So that was taking some time because you can obviously count number of contact attempts. You can sum up number of contact, like how much time is spent on each contact. Those we can do easily. The harder part was to check the outcome, because sometimes the outcome is left a voicemail or nobody pick up, or disconnected. Sometimes it is talk to the patient or talk to a relative. So those are more successes compared to the other options. So trying to come up with features that reflect this. Another one is merging the text fields. So actually there's not just one spot to put notes. There are notes for different categories, but it's so sparse that we created one note field per patient, collecting all of possible notes about a patient and putting them in one notes field. And the vectorizer trying to experiment with that came later with the notes. Some more challenges that we have to put out there is the selection bias. So in randomized control trial, the patients are the same and you give them different treatment. Here, it's not the same because people choose to follow up or they choose not to follow up. So it's not completely fair to compare the type of patients. So we have to acknowledge some kind of selection bias. People who want to go to CHW might be already people who want to fare better or take care more of their health or are able to, right? So there's some kind of bias when we compare not engaged and engaged. But still, we can compare those accuracy because either one will show us that having the CHW program is helpful. And we can also compare the same patient with and without the engaged information, right? So that's also helpful. Integrating the tabular and the text, I will say what we did there. And then we can look into more advanced natural language processing techniques as we go. So here the table is just showing the different type of patients and what we have for them. So not engaged, you would only have demographics and referral. So where do they come from? Why were they referred? And who they are, right? When you have engaged patients, you get the logs and you get the survey answers. So you have more data. So our methods, and to talk about what we did for text that may be unusual. So we went with something more traditional in natural language processing than the latest and greatest, neural network based models. The reason to do that is that we wanted to be able to keep zeros for the patients who didn't have notes, right? The easiest way we thought is to get term frequencies for where we have notes, but be able to put zeros when we don't have them. So that would highlight the important terms and topics. It would enable us to keep the zeros, but also the problem with that is that you would have too many features, like actually 4,600 about, right, in terms of your entire corpus. So we still wanted to decrease that. So what we came up with as a twist or a novel idea, applied idea, is to come up, we plotted the frequencies of these weights, and we looked for an elbow, right? So a point where we saw things change, and we decided to use that as a cutoff point to what weight we would keep. So beyond a certain minimum weight, we didn't keep the weights, and we went down from 4,600 to about 375. That is less likely to overwhelm the 60 tabular features that we had before. So that's how we come up with that integration technique. The reason, so we picked three base methods because we wanted them to be explainable and give us feature importance, since we want to say what are the mechanisms that are helping the patient. We used AUC as a metric for comparing models. And then we were able to zoom in on only so you want to keep zeros when you don't have notes, but you also can look at when you do have notes, how far can you go? And so this is a sample results from our most recent paper. We looked at AUCs. What's interesting is that for the non-engaged, we have 0.66 plus some error. And then for the engaged, we have 0.6. So it looked, compared to what we had before, where engaged was worse off. I think it's because of all of the zeros also confusing the model, but for not engaged, because the notes were not helpful, it actually went down when you added notes, right? When for engaged, when you added notes, you went up by 11%. So there is valuable information in the notes, especially when the patient is engaged and the CHW are able to capture something about their, their health. And this has been our result, that when we have engaged patients with all available information, we are usually able to go up 5 to 10% from like the baseline, right? And so if you focus on patients with notes, then you can go up to 0.74 AUC with all of the available data for these patients. That was our main result, most recent result. And also the other interesting piece is what can we do about feature importance? So we can do it for tabular data, which we had done before. And the first step was just to show that not only we can increase accuracy, but the important features come from the CHW program. So for example, there, visit number is how recurring visit, right? So that you can say is not necessarily CHW, but from the second one, you have the outcome of contact 4. You have food and SDOH survey answers, right? So you quickly get into features that are directly related to the CHW program and that pass the demographics. When you don't have demographics, the accuracy, when you only have demographics, the accuracy is low, and your main factor is age. Actually, you were asking about age, right? So the main thing that the model has to go on is the age to decide. But when you add the features from the CHW, a lot of them pass by the demographics, like the outcome of the contact, sum of the contact, the time spent, right? The total time spent with CHW, those features come before the demographics. So we can say the program helps, and we can say the important features are related to the program. Now, what happens when you add text? You see text features also coming up in front of some of the other feature. Outcome contact 4 is still there, or contact 6, and different tabular features, but you also start to see words like, and I will come back to read bit a bit because there might be some leakage there, but you see terms that are, you see tokens that are from the notes also surpass the tabular data, like PCP, primary care physician, for example, or left voicemail, right? So we can say now also that the notes improve accuracy, but we can also see it in the feature importance of the XGBoost model. The last thing that we did that was kind of interesting, or I think novel, because of application, again, it's about how we apply the work. It's not that we use new models, was that since we tried this, we did not just try one model, we tried several. We settled on these 3 top models, but we decided to look at the top 25% features of all 3 models and compare them to each other. And we found an overlap of about 14 features, so 14 key terms that were relevant for or important for all three models. And there we see contact, leave, primary care physician, Mount Sinai Hospital, list need, hospital pain, right? So we see several words that are related to the notes, and that we could dig deeper into why they're important in predicting the readmission. I will come back to the fact that, well, I can say it already, the fact that readmitted is there is somewhat might be a leakage because we combine all of the notes, right, for a patient. That means that we lost the aspect of time. It's possible that some of these notes are after the fact. So I would not give as much credit to like readmitted as to contact or leave or PCP, for example. So that made us realize that we are overlooking time in our notes when we just concatenate them to improve our results. So still, we can say that it indicates the key role of communication between CHW and the patient in terms of important features in addition to the tabular data. So our finding, again, have been that we consistently, you have at least a 5% improvement when you use the engaged patients and all of the data you have available for them, and sometimes more. One thing that is good about this project, and hopefully I'm not over because we started a little late, but I will come back to that. I think one cool thing about this project is that some important features, even since the tabular data, were time spent with CHW, right? So this is pointing to the human touch, the patient connecting with the CHW. In terms of comorbidity, Kelly is here, so she can also talk about this, but we noticed something with hypertension. Diabetes is also there, asthma is also there, but the difference between readmitted and admitted was not that different. However, for hypertension, there seems to be a problem with patients with hypertension coming back more. So we are trying to get that out there. Food security and insurance. In terms of SDOH that matter, this was an important also finding that in terms of saying that social determinants of health matter, food security came up high in terms of an important feature for readmission. So that we did publish about. Now, the notes, we need to do more work. We have some common understanding of like important terms. Like I said, readmitted, I may filter out, but understanding why contact and pain are important, I think we can dig deeper into and solve the leakage problem. And I want to note here that these are not clinical notes, they're CHW notes. So really they emphasize the role of the CHW and not just going to the hospital. And so now we get into the grants because that's what started the work, and I continued. We got an NSF grant, and in this grant, what was different or novel is how we propose to get all of this information integrated from the SDOH data, the EHR data, which now we do have after a couple of years to, try to get it because it's very hard to, there's a lot of regulation around health data, as you may know, and trying to integrate it to help improve the health outcome, which is still readmissions, but also we want to go beyond the readmission and improve the resource allocation. Where do CHW focus their attention, which patient they should see first, and then continue to improve that community connection. Elements of the grant were that we needed education sessions to be able to take input from the CHW. Our argument, and I've heard it other places too now, is that you should increase the data literacy and the AI literacy of the people that you want to get input from, right? So for them to be able to help, we need to tell them some minimum about what is the model doing, what is the model looking for. And so we have started this kind of education sessions and this focus group to get information from them. You have a question?
Was that to incentivize them to take better notes?
Yes, actually. So this is exactly what one of the outcome is. Maybe we can even auto-generate some notes that they can edit and put in, right? So that could be definitely one of the things that we're looking for.
And I'll also add, so our CHWs, they don't love documenting things. They don't
More
love
for them.
data. They love
Yes.
the human interaction. They see any time away from that human interaction as taking away from patients, and it better be really important. So part of, I think, what this is helping to do is to showcase, like, we're actually doing something with the data that we're asking you to input. There actually is a purpose behind you recording everything and documenting everything. It's going to benefit the patients in the long run.
Yes. Thank you. Yes, that's an important piece of what we. And we have started this focus group. This is John at Sinai giving one of these focus group. So we still want to characterize the importance of the CHW and the health outcome of the patient. We still want to identify the prediction, the resource allocation, but we need to start by learning from the CHW, and that's the main point here. Now, one of the things that we discuss is that we want to design a model that is user-centered, community-centered. Now, human-centered design is something that it's not something new. So this is a Stanford methodology where you start with empathize, define, ideate, prototype, test, and assess, right? And so this can be done for any type of tool. But now we are saying we should do that for AI. So we want to enhance how CHW access information about patients. We want to follow this 6-step process, but with them at the center, make them part of every single step and get their input, go back and forth. And while we design this, we are just at step 1, but that is the goal. Meanwhile, I mean, it's not like the data scientists are not we constantly learn from each other. They learn data science, we learn their application. We want to involve them at the center. This addresses trust because they are the center because the patient would rather talk to them than talk to a machine or somebody at the hospital, right? So anything we can do to address trust, transparency, interpretability, so that it's understandable to the CHW and the patient, that's our goal. This is just an example of the CHW getting together, answering questions about, this was one of our sessions where we tried to tell them about data. So we asked them to answer questions about grouping some of the questions that they ask. And then we showed them how we could take all of their collective inputs, right? Use MDS to visualize like where they sit with each other, where they agree, what things were rated together, what was not together. So this was an example of exercise that we do during the focus group. And then this was also cool. After they did that, and we did a collective ranking of their feature importance, we showed them what the data gave them. And this is also interesting for us because it points out some things, like, for example, the fact that this data was collected earlier, maybe their priorities have shifted a little bit away from things like COVID and things like that. There's some agreement between data and people, and there's some disagreement that help us, decide, oh, what happened here, or discuss around that. So diabetes is up for both of them. Asthma and hypertension are pretty close together, right? And the interesting thing is how food was rated highly by the model, but the CHW are now more concerned about housing. And this is when we discussed thinking about how there was an influx of migrants and they had to find a lot of housing, right? So priorities can also shift. And that was a finding from here. Right. And finally, I'm on time. I want to take some lesson learned from this, and I hope you find them interesting. So as a data scientist, we want to predict, we want to cluster, we kind of have an idea what we want the model to do. Now, it takes some adjusting to realize what the CHW wants, right? So they are expert in what they do. They want to connect patients to resources, and we need to pick the right problem and think about the real world impact of our model instead of focusing on what we want to do, focus on what they want to do. So that's how Scholar is trying now to say, yeah, readmission is still a goal, but the goal now is really prioritize patients who are in more need of, like, who should be seen first. Also, we are learning so much from them. We are learning that different CHW have different expertise. Some of them know more about maternal health. Some of them know about aging. So try to match CHW and patients more efficiently. AI, this is a place that AI can help rather than one person trying to do the scheduling daily. And to your point, facilitate record filling so that they don't have to do all of this input, right? We could be doing some for them. First of all, they would be giving us more data because they understand what we are using it with, but we may be able to pre-fill some of these fields for them so that they can just quickly change them and submit it. So that's some of what we learned. There's so many places to go from here. Scholar is supposed to be a dashboard, so improving the visualization is going to be a goal, implementing that dashboard. Integrating the EHR is going to be another big topic. And the idea there is maybe you cannot help everybody with CHW. I mean, we know, as Kelly mentioned, that some readmission need to happen. Some people need to come back and see the doctor. So if you know that the reason is medical, that's another type of intervention. That's not CHW, right? So this could help us detect who should be directed to CHW and who should be maybe going back to the hospital. A big topic is cost, and it keeps being future work, but I think now we may connect to somebody in the business school finally. When we say it improved 5% prediction, it means something to us, but for the hospital and the insurance to care, it would be good to have dollars attached to these improvements. So having a cost analysis of the same model and having money attached to it is going to attract more support from the hospital and the insurance company. And of course, there's a lot as we are learning, we can shorten the survey, we can emphasize some answers and give a better survey. So, I mean, the takeaway for today, I hope, is that you can, I think we should, as a society and as developers, pick the right problem, focus on the real world impact. I mean, companies are always, I just talked about money for a good reason, but usually companies are incentivized to like just make more money. Responsible AI is about picking a problem that is good for society. So you want to keep the human and the community at the center of every step of the data pipeline and focus on keeping that human touch. So that was my talk. Thank you for your time.
So what were some changes that modified process after going through this like study? Like, what were some applied learnings that happened?
One of the specific is not focusing so much on ED readmission. It was our entry point, right? But it is not like the priority of the CHW. I mean, this is just one of their many concern. What they want is connect patients with resources. And that is a challenge. And I skipped over this, so thank you for that question. It's a challenge because right now we are assuming that if there's a need, it's addressed, and we can kind of see that in our data, but they're very interested in checking that these resources are used, right? Like kind of getting a feedback on what they're doing and how it's helping. So finding out if those connections are being done. That was a big shift from our perspective to their perspective. If that's
So efficiently deploying the right people to the right patients.
I think on our end, it's more a matter of triaging which patients truly can, benefit the most and need the most CHW help, because we have so many patients that we would love to see, and only a team of about 7.
Yes.
CHWs.
Wow.
Yeah.
Yes, and this is what I wanted to say there. So there's more patients than there are CHW, right? So they're always behind, they're always not sure that they've seen everybody they can. So being able to triage and prioritize high-risk patient or patients that are more that will benefit more from this intervention. I think that is a big common goal.
So data importance is of course very important. You have shown that the model level data importance. I'm wondering if you have data importance at the patient level per patient. It's really help the CHWs.
Yes.
Speed up their decision and to prioritize.
That's very good question, because that's what we're talking about doing, but we could have looked, like you said, about like the probability. I've been saying that that's also a step, the probability of high risk, and playing with the AUC and prioritize patient just with this model. We haven't done it, but it's in the works. Yes. Yes, because actually what we have, which I didn't mention now, is what we have found out. Another thing that we found out is AUC is great. We can see it's learning, right? But if you translate that into sensitivity and specificity, the sensitivity was actually pretty low, right? So we need to play with that risk, that probability score to figure out how to catch the really, the readmitted people. We are going to do that. And at the same time, focusing on a vectorizer. So now we're using BERT vectors. When we have notes, this is helping increase the sensitivity.
It's turning text to vector.
Yes.
Okay.
And we did it with the term frequencies, and we had some results, but like I said, sensitivity was low. Now, when we use these BERT, this is a Google large language model. When we use BERT vectors, it seems like we can increase the sensitivity, but that's with patients who have nodes, right? So we need to do it both ways. We need to do it with the old data and the new features too.
I'm also curious that how often do you think that the model needs to be trained?
Yes, because that's another thing that came out while meeting the CHW is realizing, oh, now they're more focused on housing. They're not focused on COVID, right? I think it should be, ideally, if this dashboard is running, it should be retrained often. I don't know how often, but often. Another problem is that when they're looking for resources, they, at the time, the housing problem, you give one resource and then maybe next day it's not available. It's full, right? So I think there should be an engine in the back, at least like search, keeping things up to date as much as we can. Now, the model itself, maybe every month, right? So something like that. But big events like migrant surge or COVID or things, they or ICE. Right. Recently, our latest meeting, they noticed they were having no information about immigration. This is not because it disappeared. This is because of the time. So I think this is another mismatch between what, model training is doing and real life. And I think it should be, weekly or monthly. That's a very good,
Yeah.
yeah.
It's
Yeah.
so interesting to see like how drastically things change with, the political climate, even like the literal climate, like seasonality in Chicago, like violence soars in the summertime. And then wintertime, we're probably going to see a lot more housing issues. Like it's just, dependent on so many external factors.
Yeah.
Other than the patient.
Oh, this is almost suggesting that bringing in the time information.
Yes.
Those records as factors.
That's, yes,
And the season, the month, so on and so forth.
that's true. Yeah, that's another thing that happened. So we have meetings weekly and monthly with a bigger group. And when the database person was reporting on how many resources they allocated this time, etc., there was something about allergies and or something about asthma,
Yeah.
something about asthma. And then the database person was surprised, and one of the CHW said, well, it's the season.
Yeah.
Right? So there are some things that they know, again, that the model doesn't occur to just data, right? But
So sorry.
no, thank you. That was good timing.
So I understand that we need to finish up before 5, but yeah, feel free to get more snacks and
Yeah.
have more discussion.
That's right.
Before 5.
Let me know if you have more questions online or here.
Yeah, online, yeah. Any questions? Usually we have questions, a few questions from online participants. And what's interesting about them is that they come from all over. How could we open it up? Maybe
I can look at the chat, but I think there's no question now.
What's a way to increase the response rate? You said about 45% are engaged with CHW.
Okay, that's a very good question too. And all of these things we come up in our meetings, right? I think one way is to tell more stories about successes. So one thing that we think we can help too with that, but they are also usually working on is how to tell the story of, sometimes they get feedback and they don't get a lot of feedback. This is kind of an ungrateful kind of work, right? They want to know that how their work matters because they're most seeing problem. But once in a while, they will request patient stories. So patient would report on, I had this problem and this thing happened and you helped me. So I think AI can also help there to tell better stories about the CHW and the patients and show the patients what happens if they are engaged, right? Because we can't force them to give more information, but we may incentivize them by just telling them success stories from the CHWs. Yeah, that's also something that we're thinking about.
And then for the surveys, since you said they're a bit longer and you're
Yes.
trying to maybe shorten them up,
Yes.
I think there's a language barrier with maybe understanding the questions or relatives are helping them answer these surveys.
Yeah, there is. There probably is. So right now, that's another thing we looked into. And in this matching of CHW and patient, language is a big thing, right? Because some of the patients are Spanish speaking. We found mostly English and Spanish. I think that could be a reason why that's another place AI may help. Maybe if we automatically translate more, right? Because they may not have enough Spanish speaking CHW for all of the patients. So yeah, that's another place where maybe it will make a difference if they have an easy translator, right, in the system and how we collect the information.
Maybe like translate the survey into Spanish too.
Yes, and collect that. The tricky part is like this CHW are this trusted people, right? So they don't necessarily want to talk to a machine or a chatbot. I don't know if they will work, but I think it's something we should explore. The idea is if we can promote this program, get more CHW, because this is also something that is not as widespread as we could be. If we can show this will impact more clinic at Sinai. Not every clinic at Sinai has them. Not every hospital in Chicago has it, right? But I think if we can make this more popular, at some point, there will be enough, resources for the demand. So, and that's a very good question too, because we say right now we're saying we can predict them better, right? And eventually we want to say that we reduce them, right? But right now that's not what we're measuring. We're just measuring if we can predict better. I think to put it in place to check that you put it and you're reducing, I think it would take a little bit more setup. We can only simulate that if we can predict better. And this is what I want to do with the cost. Say that without the CHW data, the readmission is 33%. But when you add this, now you can predict better and you can address the needs for, so many. Then you can show you're reducing it. We don't have the quite the setup to show that we are reducing it, but that's the ultimate goal. Yes. Yes, yes.
And then how long do CHW workers spend on documentation? Because I have like a health background and I've like heard from like social workers, nurses. It's just hard to document and.
It is hard, yes.
They spend about 5 minutes, they rush the next patient.
And that's why we don't have a lot of data, right? So they give what they can, but I think it's cumbersome for right now to have to enter it in the database. And plus they have like multiple systems. And so that's, we find out, to answer your question, that this, if we can help them with that, they'll be happier, right? They spend a lot of time documenting what they're doing in different places and looking up the patient information in different places. That's not their favorite part.
And
Thank you very much.
Thank you. Thank you for having me. I know, I'm gonna touch this.